Hello everyone and welcome to this episode on Complete Dentures with Dr. Mark Bishop. Dr. Mark Bishop was actually one of my first ever, he was my first ever clinical tutor at dental school. It was in second year, early in second year doing Complete Dentures, and what this guy doesn't know about Complete Dentures is frankly not worth knowing. We share so many great gems as always. We talk about talking to your dentures patients or your denture patients about expectations, how to manage occlusions in dentures. We talk about which is the best impression material for dentures. How can we get a lower suction denture? Is there a technique or is there something else that's there to it? Another couple of things we talk about is red flag patients and how to identify them, as well as at what point do you actually say, actually, this patient in front of you will actually benefit massively from implants and actually the dentures just won't cut it. So that's something I often think about is actually, with such a resorbed ridge, are they going to get any success with this complete denture I'm about to make, or do they actually need to have implants, as in need to have implants? So we touch on that as well. The protrusive dental pearl I have for you, quite fittingly, is actually mentioned in the podcast episode, but it's something that Dr. Mark Bishop taught me about complete dentures. And it's basically when you have a patient who has complete dentures and an ulcer due to the complete denture, and you're trying to adjust that bit on or ease that denture so that it's not rubbing against the denture anymore, so it's a bit more comfortable for them. How do you actually know exactly where to adjust so you're not adjusting inappropriate areas or adjusting too much, and you only want to adjust the fitting surface where the ulcer is? So what Mark taught me to use, what I still use to this day, is the only reason I have Dical in the practice. I use the base paste of the white one of Dical, and I put it, dry the ulcer, and I put it a little bit around the ulcer area, and then you press the denture on, you actually insert it in, you press the denture on, and you remove it, and you'll have the base paste of the Dical on the fit surface of the denture, so now you know exactly where to adjust for that patient. So I hope you enjoyed the episode with Dr. Mark Bishop, and I'll catch you in the outro. Right, so usually it's Dr. Mark Bishop, but in our relationship, I know you're happy for me to call you Mark. Mark, thanks so much for coming on the Protrusive Dental podcast.
It's a pleasure, total pleasure.
You were my first ever clinical tutor at dental school.
Really?
Did you know that? Yeah, because we did complete dentures.
Well, yeah, because it's the first thing you do, isn't it? Complete dentures.
Yeah, and it was, you set the bar really high, and to be taught by other dentists was never quite the same as being taught by you. And I'm being serious, I'm being honest, and you are an asset to dental school. However, I don't know, are you doing much teaching anymore?
Yeah, I still do 2 days a week. As you know, I sold my practice November 2019. So time for coronavirus. Although obviously I didn't know it at the time. I feel very, very lucky to have been able to step away at that time. I feel really sorry for you guys who are still having to work at the coalface now. It's very difficult for you. But no, I carried on doing 2 days a week. So I'm now a part-time dentist, which is quite nice.
Brilliant. And this episode is going to be all about complete dentures and how we can make it easier, more predictable, some tips that we can share with the listeners. So tell us, as part of the introduction, how did you get into complete dentures? I know we all sort of dabble per se, and now they say more and more that complete dentures has really become almost like its own postgraduate specialty. But how did you get your enjoyment and fulfillment from complete dentures that you do?
Well, I always knew that I didn't want to work 5 days a week in practice. So quite quickly after graduating, about 18 months after graduating, I sent a bit of a cheeky letter to Charles Clifford in Sheffield and said, do you want any clinical tutors? So I ended up getting there and realised that it was something that I'd got a bit of a love for. And then I did a master's, which was a general restorative master's, because as you know, I didn't just teach complete dentures, I taught restorative as well. And I got to know a guy called David Lamb, who became a little bit of a mentor for me. And I just really enjoyed it. I love what's the nicest way of putting it? You're not sticking injections into people. So you're not you're not potentially causing discomfort. You're doing full mouth rehabilitations on everyone you treat.
Yep.
And just you can kind of have a bit of a nice chat with people. So I always find it quite a low pressure side of the job. And I never really saw it much as dentistry. I saw it as a hobby.
Well, I have to say, it certainly came across that way when you were teaching me, both during second year, and also we had a few sessions together in like fourth and fifth year. And I've seen since I've qualified, you've started doing some complete denture courses around the UK.
Yeah, I try and do about 3 a year now, because I understand it's a subject that undergraduates don't. I mean, even at Sheffield now, our current teaching is a shared set of dentures in second year, and now we've moved to the same model, shared set of dentures in third year. And then you go out into general practice, and very often people have done that. That's all they've done. And they go out into a field which I personally think we make it more difficult than it has to be. But we go very unprepared, and then people suddenly start treating patients, realize how difficult it is, and then they need a course to maybe understand, little tips that they can improve what they do on a day-to-day basis.
Well, it's the same as crown preparations, root canal treatments. Dentists nowadays, we're qualifying with less and less of the quota for each of these procedures, and complete dentures is no exception. So we're going to hopefully improve the complete denture removal prosthetic dentistry of everyone listening. And the first question I have for you, Mark, is, so you could have a very technically excellent denture, and you have a patient who has a certain ability to adapt. So there's the quality of the denture on one side, and there's a patient's ability to adapt. And I think sometimes people call this the neuromuscular adaptation or whereabouts. So how much of the success of complete dentures comes from it being a technically excellent denture, and how much of it comes from the ability for the patient to adapt, which is more important?
Okay, good question. We can only work with things that are in our sort of ability to cope with. Okay, so that's the dentist and the patient. So what can we directly affect? We can directly affect the impression technique that we can take. So there's good evidence base to say that the quality of the impression will have an effect on the standard of the denture. Okay. And the other thing we can affect is the registration stage. So again, there's good research to say that the registration stage gives good results if done accurately. There are things that are way out of our control. So whether a patient can adapt or not adapt is out of our control. So really, we've got to concentrate on what we can do. Now, going back to your question, some patients obviously adapt better than others. But most people we see, I would think, are having replacement dentures. A small percentage are having the first set of dentures. So the people having replacement dentures know how to wear dentures. And what happens sometimes with dentists, we kind of blame them that they're not adapting to our new dentures, when realistically, if we'd have copied the good aspects of their old dentures, they probably wouldn't have to go through a major relearning curve.
Fair enough. Well, one thing that I think you taught me this, I can't credit anyone else for this, is that when someone comes in who has a technically rubbish denture and they're able to get along with it, I get so happy. And if I'm the next dentist who's going to make them a new denture and they're already adapted to this rubbish denture, and I know that I can only technically improve this denture, that for me is, okay, this is going to be hopefully a home run.
Okay, so it's a home run with some potential pitfalls. So some of these patients can be people who've worn dentures for 35, 40, 50 years. And they come in with a set of dentures that look like they've been through a cement mixer or something. They're all over the place. And then what happens? People go, okay, there's loads and loads of technical faults on these. I'm going to correct them. And what the dentist often does is makes the mistake of turning them back to the ideal denture. So they don't measure the freeway space of the old set of dentures, and they don't have an assessment of where that's at. So let's say, for sake of argument, you get patients who have lost a dramatic amount of face height. and they've had the dentures for 35, 40 years. You make them a set of dentures that technically you look at and go, wow, they are brilliant. But you may have changed the freeway space from something like 17, 18, 19 millimeters to 3. Now, there's no way in this world that patient's going to adapt to that. They're going to have to adapt to it through stages. And in situations like that, it's part of training the patient to say, look, we can't make you look perfect. But what we can do is maybe make your dentures a little bit bigger. And then in 3 years, we'll make you another set, which we can make the dentures a little bit bigger and gradually turn you back to having a perfect set of dentures. Although I'd like to just take the word perfect out of that, because I think perfect in dentures and perfect in dentistry doesn't always go together. You can't do perfect. You can do the best you can do.
Yep, brilliant. And I think that's exactly what you taught in terms of the freeway space. I actually remember vividly second year clinics, and we had the patient a freeway space of 12. I remember you saying, we're not going to go down 2, 3, we're going to go try about 6 or 7 or thereabouts. And actually remember you teaching that actually very vividly. The next thing I want to ask you, I want to start with my experience. And I did my DCT1 post in Guy's Hospital. I don't know if you know Dr. Lyndon Cabot.
No, not come across him.
So he teaches the removal pros at Guy's Hospital, and I did a complete denture clinic with him at hospital there. Lovely chap, very knowledgeable, very passionate like yourself about removable prosthetics. And I remember him having a study group with us, and he sat us all around. And there was about maybe 8 or 10 of us DCT1s, and he went around the room asking each one of us, which you have a patient in front of you. You've got your special tray, okay? Which impression material will you use? And he went down in the room, and each person said, oh, yeah, I'll use alginate, I'll use zinc oxide Eugenol, which I know is a favorite of yours. I said, I'm going to use monophase, I'm going to use medium body silicone, okay? And the mistake we all made is that not one of us asked Dr. Cabot, well, actually, what does the arch look like? What does the actual arch look like? Because that will determine what kind of material you're going to go for. So that question leads nicely to, can you give us some guiding principles about which impression materials, when you're choosing impression material to choose, which ones do you tend to suggest, and what changes your decision making?
Okay, so a couple of things there. Firstly, there isn't a perfect impression material. You know, you can look at all the research, and you can't do a double-blind clinical trial on impression materials because, do you know what? The clinician knows what they're using. It's impossible to do. So everyone gets their own little thing they like to work with. All impression materials work, okay? But the trouble is a lot of people use them poorly. So alginate's my favorite for discussion. So alginate works perfectly well. But alginate, like most materials, works at an optimal thickness. So it works at 3 millimeters. Now, if you use an alginate for a resorbed lower ridge, it's useless. It's impossible to use because ultimately you can't really get 3 millimeters of space around the edges of that and to get alginate to use in its best way. So alginate's a very, very good primary impression material. Secondary impression materials, I never use alginate ever for secondary impressions. I use zinc oxide, as you say. I really, really like it. And I like monophase silicones. With monophase silicones, again, you've got to remember that they have an optimal thickness. So if you're going to use a monophase silicone, ideally try and get a 1.5 millimeter tissue stop on it. And you need that space at the periphery as well, because if not, you're going to record in your borders in the tray, which is not particularly useful. For me, the only time I steer clear of my zinc oxide is when there's an excessive fibrous ridge, because I don't want to compress that tissue. I want to record it in a static position, because anything that you compress will want to bounce back into its usual form, which is not ideal under a denture. And I avoid it in people with excessive xerostomia, and I avoid it with people who have not just, I get a bit itchy after wearing a plaster for 7 weeks. People who have proper allergies to elastoplast. Apart from that, I stick with it. The other case I sometimes I do avoid it with is excessive undercuts, because obviously you're not going to get it back out of excessive undercuts. So really, stick to what you enjoy using. Just use it correctly.
Other than the undercuts, is there anything else in the anatomy that that might change? Your you from moving from one material to a different material based on anatomical considerations?
Well, again, I think we can go back. The more atrophic the ridge is, the more you want your impression tray to simulate the inside of a denture. So the bigger the tray is, the bigger the problem you're going to get, because you're not going to record those muscle movements that you want to record to get the best result. So no, really, I think fibrous ridges avoid zinc oxide, severe undercuts avoid zinc oxide. But I think one of the reasons I get good results is because I'm very consistent at my approach. I think a lot of young graduates, instead of thinking, what is it that caused the problem, they think it must be a panacea of an impression material that's going to give a perfect result. And it just doesn't. It's about practice and getting good at things. So many people start with good intentions. They're going to use a material. They do it 2 or 3 times. They're not getting the results they want. They blame the material. When actually it takes time to practice anything. Nobody picks a guitar up and bangs out a tune straight away.
Awesome. The next question I have then is moving away from the impression material, is more about looking at the patient in a broader perspective. Can you tell us about which red flags can we watch out for in our patients?
Okay,
because I know there's
the red flag patient. Okay, so this is where I think most dentists go wrong. The lack of that ability to say, do you know what? I think this is beyond my skill set. So you get things like endo, and it's a multi-rooted, difficult endo and a 7. People wouldn't think twice about going, right, that's out of my skill set. I don't think I can do that. Or it could be a full mouth rehabilitation, or it could be ortho, something like that. But with dentures, we all have a go at whatever comes through the door, and that's where the problems start. So I have got some red flags. Okay, so if anyone comes into me and says, I've never been happy with my lower denture, I know full well that the chance of even me, who's done 2,500 dentures in his career, solving that problem is massively reduced. Okay, so that's one. Another one where people say, look, I've been to so many dentists and they can never get the appearance right. Again, boom, big flag, starts to warn. What, they've all not been able to do it? And, why will I be the one that solves that problem? There are people who want to design their own dentures. So they'll come in and they'll go, right, I have a loose denture. And you'll take the denture out and the palate will be halfway back along the palate. And they'll go, well, yeah, but I can't have it any further back than that. And but I want it to be tight. Mm-hmm. And not having that conversation to go, look, you choose what you want because you can't have both. So that's another one.
That's a tough conversation to have, isn't it? To, for a young dentist to say to someone in their, latter stages of life to be like, well, hang on a minute, there's only so much you can do. It's a difficult conversation because sometimes these patients, they almost tell you, oh, I think you need to adjust it over here, lad. Just over there. I think if you do that, that'll do the trick or whatever. So I think they can be quite dictating if they see a young dentist and,
Yeah, absolutely. They love it. They love it. And watch out for certain professions as well. So engineers, head teachers, and people are used to telling people how to do things. And I know it's a generic sort of picking on certain professions, but people who have a lot of control in their life like to tell young professionals how to do things. I have a way around that, which is, you remember PSI paste, Jazz?
Yeah.
When you were an undergraduate?
I bought it for the practice. I still use it based on your teachings, yeah.
Perfect. So what I do with that, with engineers and people who are quite strict, is I tell them what I'm going to do before I do it. So I say, look, what I'm going to do is I'm going to load up this impression material around the edge of your denture, and we're going to press really hard. And what it will show you is where it touches your mouth. So anywhere other than the point that tells me, I won't adjust. And I won't adjust it because it's not in your best interests. So if you're getting pain from your denture, it's not being caused by the inside of your denture, it's being caused by something else. So it could be the way your teeth come together, Or it could be, do you know what, you're very stressed as an individual and you clench your teeth. And it doesn't matter where I adjust. If that's the case, it's still going to be a problem. So that's, I understand. Mm-hmm. As a young dentist, you need to have skill sets that you can do, like go-to ways of proving a point to a patient. Never, ever do that in a non-scientific and a non-technical way. Mm-hmm. You have to be able to say, look, this is what's going to happen. I will show you. We'll look what we get, and then you'll understand why adjusting that denture is not in your best interest.
No, I really like how you explained that, to actually show them, oh, these are areas I can adjust, and you give a reason as opposed to, no, I don't think so. You justify it. And for anyone who's listening who doesn't know what PSI paste is, it's pressure spot indicator paste, which I don't know which company makes it.
It's made by a company called Coltine.
Okay, Coltine, yeah, sure.
Yeah, so it's a must. And remember, when you use it, and get your nurses to do it as well, make sure they understand why one tube is wide and one tube is narrow. Okay, you don't put the same amount in. You put the same length in, but you keep the nozzles to the width. It's really important. Otherwise, it's going to set far too quickly and it'll be non-diagnostic.
Did you have any more red flags, or should we move to the next question?
Yeah, let's have a look. Secret denture wearers. You had any of those yet, Jazz?
I think so, because they don't want to remove their denture at nighttime, because they don't want their partner to see, because they don't want them to. Is it that one, or is it because in public?
Absolutely, yeah. People who don't want to be seen without their dentures. So that's a red flag. There's a potential degree of neuroticism attached to that. That it's quite reasonable. I can understand why people wouldn't want to be seen without it.
I was just thinking, it's very reasonable.
But when it becomes a be-all and end-all that I couldn't possibly, you know the types, Jazz, that you've met. I'm sure you've met them before. It would literally be the end of their world if they were seen without their denture.
Yep.
People who say their dentures are loose. Have you ever had that, where you have an upper denture, patient say my denture's loose, you actually try and pull it out and you virtually have to put your knee on the chest to get it out. And yet they tell you that upper denture's loose.
I haven't had that. That's my lack of experience compared to you showing. I haven't had that one. I've had it once in hostel where it's a fantastic, if I may say so myself, a really textbook denture. I made upper complete, fantastic suction, but it was an error I had made in the occlusion that he said yeah.
That's always the problem. So when somebody says my dentures are loose and you try it and you feel good retention, then it's always occlusion. Okay,
that was my error in that case, yeah.
Yeah. And the other ones are, does anyone talk to the patient about use of adhesive? Do you do that, Jazz? Do you ever speak to your patient before you start about the need for denture adhesive?
I do say quite a lot of time people will need a bit of adhesive now and again, so that it allows your denture to stick on and stay on better, so that they are already in the mindset that should it be a challenging case and we cannot get adequate retention without the need for adhesive, then they're already mentally prepped for it.
Okay, so again, that's another red flag for me. So if a patient's got a horror of using adhesive, and anatomically you look at them and you go, do you know what, that lower denture is going to move, it's far better to tell them at the start that you're going to need adhesive, but guess what? Adhesive's not very good on lower dentures. And I explain about gravity and how the adhesive's going to come out, your saliva's going to wash it away. Because in the end, adhesive really helps dentures, and even a well-fitting denture benefits from adhesive. So they're the sort of red flags. There's quite a few like that.
Well, following on from the last one you said about the use of adhesive for a lower dentures being so tricky and traditionally, because of the anatomy, very difficult to get good stability and retention. At what point do you look at a ridge and say, you know what, you actually generally need a couple of implants, maybe as part of an implant retained overdenture or an implant supported prosthesis, and you think that with any complete denture in the world, you will not be able to satisfy them. What is the cutoff point? I believe the classification of ridges is it the Atwood's?
Atwood classifications.
So can you put a classification on it? Is that how you like to teach it? Or what can you teach us to know that what point we should be looking for? You know what? Actually, we better send you to an implantologist. In a quotation marks.
Right. So basically, I've just been doing a little bit of a study with a friend of mine called Johnny Dixon at Sheffield. And what we're doing is we're looking at what comes through the door when we see people and assess them for undergraduate care. So on the lower ridges, I've just flicked this up because it's in front of me, okay? Out of 60 patients I saw, 25 out of those 60 were outward 5 and 6. So that's flat ridges or depressed ridges, okay? So that's nearly 50% of every patient that comes through your door is going to have one of those ridges, okay? So would all those people benefit from implants? Probably. Would they economically all be able to afford it? Definitely not. So we have to find a way of trying to solve those problems for those patients. Again, lots of studies are out there that show that patients definitely would benefit from 2 implants. But what's the going rate for a lower implant retained denture down there, Jazz, at the moment?
For 2 implants and a denture, maybe
and a lower denture?
Yeah, £7,000 probably. Yeah,
so even in the north, we're looking around the 5 mark in some, people who are reasonably priced. And that's way outside what people can afford. Because if you think of the demographics, very often, not everybody is in that income bracket where £5,000 or £7,000 can fall into their lap. So going back to your question, how do you decide? Well, economically, pretty much most of them would benefit.
Yeah.
Economically, if they all had the money, they'd benefit, but they don't. So you have to work a way of taking accurate lower impressions, and you have to educate your patient from the word go that, do you know what? I show them in the mirror, I show them the upper denture, I show them the upper ridge, I show them the amount of surface area I've got, and then I show them on the lower. And then what I do is I show them when I push their denture to the right and push their denture to the left. It's not that the denture's loose. It's there's nothing to stop it moving laterally. And again, it goes back to what I was saying to you early on. It's all about that educational first meeting you have with your patient. If the patient's not on board with it, they're not the patients you can do anything for, because you're going to fail no matter how good your dentures are.
Yeah, I like that tip of actually showing the patient in the mirror as you move it around. I think it really rings it home for them.
And I also talk about it being a bit like a windowsill. So I show them the lower ridge and I show them where the anatomy is, and I say, just imagine your denture's on a windowsill. You open all the windows and there's a strong wind blowing. Okay, it's trying to blow it in one direction, and you're pushing from the other direction, trying to push it out. And you're trying to push, and the wind's pushing back. If one thing overtakes ever so slightly, the denture's going to move. And, you can't talk about neutral zones to patients, but if you put analogies like that they can visualize, it helps them a lot.
I love a good analogy. I think Raj Patel used to say a good one to patients about when they had lower dentures and that they were in pain. And what Raj was trying to convey was the fact that actually it was the lower arch, which was quite bumpy. That was the issue. Bony prominences. So it's a bit like when you go to the toilet and you sit on the toilet seat, and then now when you imagine you have, I think, like pebbles on your toilet seat and you sit on it, it won't feel so good. Even if you put some toilet roll on it, it will still hurt, like using a conditioner or something like that. So I do love a good analogy. So if you have any at the end.
I'm glad Raj managed to get some toilet humour in there. Very good, Raj.
He always does somehow or the other. So the next question.
The one I like, Jazz, on that, analogy I like on that is the camping analogy. So if you go camping, you can take a thin blanket and put it on the ground, and you're in a pebbly field. And you might be able to get comfortable if you just move into one position. But if you move from that position, everything's going to start hurting. And your mucosa is that blanket. Okay, that might be. I like that very much.
Well. Raj is full of a myriad of fantastic analogies. Actually,
he's a wise man. He's a wise man.
He certainly is. So the next question is, moving on from the fact that lower ridges that may benefit from implants like we just discussed, and the economical issues and that. Well, firstly, the way I explain to patients that, look, you will benefit from implants. It'll be much better to hold it in. And if they look like they can't afford it, then I say we can try our best. And obviously we want to try and do a technically as good a job as possible. But at least, you've set the expectations that actually it's going to be loose. They're going to struggle, and implants would be a good idea. However, a prerequisite of making an implant retained overdenture is still a good denture. You can't 100%,
give a and that's
rubbish
what everyone
denture
forgets.
And hope the implants will do the rest of it. So that's another thing worth mentioning.
If you can't make dentures, Jazz, putting implants in is not going to solve that patient's problem.
Absolutely.
It will stop the lower denture moving, and that is it. That is the only difference it will give you.
Mm-hmm. You still need the fundamentals to get as good technically, 100%. Good coverage. So moving on from fundamentals, is you see all these videos, and I see some of your videos as well, of the lower complete dentures with a suction, and it's just so magical to see that almost. When you have these patients with lower complete dentures with suction, who would believe it? Yet you're able to do this. I've had 1 or 2 patients in my career so far where I've been able to achieve that, and it's a great feeling. It really is.
It's magical.
It really is. So, how do we know if? How best do I put it? Like, how do you know if you can achieve it? Is there something like is like a minimum Atwood classification that you can achieve it with? Okay, so can you tell us a bit more about how we can go about even thinking about getting towards that stage?
There's a big degree of luck. So if it's a bit, all dentists are the same. They tend to post their successes, don't they? And anything that's not successful, they hide. It's exactly the same. So you've seen some of my dentures that have suction. Not all my lower dentures have suction. So there is a degree of luck in it. There's no guaranteed way of doing it. Mr. Abbey seems to believe that he can do it every time. He may be able to. Good luck to him if he can. But without seeing every set of dentures he makes, I'm not going to buy into that straight away. So realistically, all you can do is do the best impression you can do. And then the most important part is make sure the occlusion's right. Because if those dentures are being discluded every time, there is no way that suction's going to stop it from moving. It will break. So there's no perfect answer, Jazz.
So you need a bit of luck and good fundamentals.
Good fundamentals, little bit of luck. If you have a really big ridge, very often it's harder to get that suction, because if you've got big ridges with undercuts, then you have to block those undercuts out. You get air gaps which are underneath, which are too big for the sort of atmospheric pressure to work, and it doesn't help. So there's no real perfect ridge.
Well, you mentioned a good occlusion on dentures as being important in getting stability. Can you give us a quick summary of what are the main things, the principles of a good denture occlusion? Is it always a lingualized or the whole bull technique to get a balanced or lingualized occlusion? Is that what you need in every case?
I think a lot of it depends on the patient. Okay, so you'll get a lot of patients who, if they are, it's a bit like the dogs and sheep thing, isn't it? Some of us eat like dogs, we incise our food. Denture wearers are sheep, they're ruminants, they move their jaw from side to side. So the more parafunctional activity a patient has, the more your occlusion better be right. Okay, you get loads of people who never complain, and their occlusion is awful on the dentures. You look at them and go, I can't believe you're not struggling with this, and they get on fine with it. So I think going to occlusion, what I would say is that if you get the occlusion right, sometimes you're going to find the aesthetics difficult to achieve that the patient wants, because in the end, denture teeth come out of a packet looking like a 12-year-old's teeth. They've all got sharp cusps, pointy canines, etc. But when you get to my age, naturally with your own natural teeth, you quickly notice that you get wear facets and grooves, etc. So everything you've learnt about dentate occlusion, reverse it round for edentulous occlusion. So canine guidance is a bad thing in dentures. It's a great thing in dentate patients. Non-working side contact is a bad thing in a dentate patient. But in a denture patient, it's what you want.
Okay. When you protrude, you don't want disclusion on your back teeth. However, trying to get that in denture cases is really difficult to get the back tooth coming into contact in protrusion. But they're your desirables. And if you aim to get those on bruxist patients, on parafunctional patients, that's where you're going to get a degree of better success. But I think the key thing with dentures is communication. Mm-hmm. It's communication. It's about talking to your patient about what is achievable.
That's amazing. I like how you talked about the different chewing patterns. So you say dogs and sheep. I also like to say the whole rats and cows. You can say what you like, and that's a good way to think about it. So to be more careful in the cows, then you be careful with everyone, but your cows are particularly important, or your sheep are particularly important to get that occlusion just right, because they can run into more problems. Now, one mistake I used to make or think about is that every patient must look class 1 or have a class 1 incisor relationship with their denture.
Here we go. So right, this is going to be an interesting one, Jazz. I'm going to enjoy this one. Go on.
Okay, good. Because that's the mistake I used to make, but then I realized, hang on a minute, whether they're class 1, 2, or 3 is dictated by their skeletal form. So we need to actually 100%. Go by their skeletal. So then I started to make dentures that were more occlusively correct compared to what they probably had before. If they're class 2 div 1 before, then I like to make their dentures a bit more class 2 div 1. The only issue I want to ask you is that with that is A, is that am I doing the right thing? And B, is if they're class 2 div 1, then you're not going to get any anterior teeth contact. Is that going to be generally okay?
Do they get anterior tooth contact when they have their natural teeth?
No, not at all.
So why do we create that when we make dentures? I mean, it's a really interesting debate. I've heard people who are really quite qualified in the profession who kind of insist every denture gets made as a class 1. It's nonsense. One of the things I do when a patient comes in, I check their sort of profile view, and I make an assumption on whether they're class 1, class 2, or class 3. Okay. And by doing that, again, I can have a conversation with the patient and say, your front teeth are probably not going to meet when I make you the right set of dentures for you. And they'll go, well, my front teeth meet on these dentures. And then I'll go, but your lower denture moves. And they'll say, yeah, but I don't want my lower denture to move. And I'll say, well, we need to set you so your front teeth don't meet. And then it becomes a bit of a circle again going round. And again, I try and explain to them, I say, look, if you've got any photos of you when you're 12 or 14, any old school photos, I'll be able to show you what your teeth look like. And again, it's having that conversation at the start, not at the end when they've got a different pattern of teeth than they thought they were going to get. Now, going back to that study I did again, so one of the things myself and Johnny are working on is trying to think of a way that we can allow guys like you to assess your patient before you start to see what degree of difficulty that patient will be. Okay, so that's what we're trying to work on.
Like an index?
So, like an index. So you can work through like a little tick box. So in these 60 patients, significant class 2. So what I'm looking for are people who I can see are significantly class 2. So 12% of patients are significantly class 2. So that takes out all those people who had a slight overjet. These are people whose skeletal patterns are massive discrepancies there. And in class 3s, there are 9%. So instantly, you've got 20% of the population have got quite severe skeletal discrepancies. Now, the way I get that round to a patient is I talk about your upper denture is for beauty and your lower denture is for function. Okay, so we have to put your lower teeth in the correct place over your ridge, as close as possible to where your natural teeth would have been. And that's the way I get around that, and that's a conversation to have with them.
Brilliant. And it's good to ask, like you say, for their old photos, not only for the occlusal element, but also for when you're designing their teeth setup as well. So leading on to that,
I'll ask you a question on that, Jazz. Okay,
yeah, sure.
So if you were going to place your canine tooth and your first premolar tooth in relation to the lower ridge, okay, where would you place them in relation to the lower ridge? Would you place them buccally?
lingually, or on the ridge? Sorry to put you on the spot, but it's a good question.
Okay. No, fantastic. So you're talking about your upper denture, where you can put your teeth?
No, we're talking the lowers, because lowers are the one that people have problems with, okay?
Fine. So in terms of positionally, whether the teeth themselves, the long axis of the teeth are on the ridge, buccal, or lingual, I think on the ridge is something I must be honest with you, I haven't thought about that much.
Okay, so you're correct. It's on the ridge. So the question I say is why? Okay, why on the ridge? So those teeth that you take out, the canines and the lower premolars, how do we take them out? Because dentistry all links up. So we've talked about orthodontic skeletal patterns. So if you take out a lower canine or a lower premolar, how do you take that tooth out? You rotate it. You don't lean it buccally. You don't lean it lingually. It's a rotational thing because of conical root. So therefore, you get a similar pattern of bone loss buccally and lingually. Okay. So your canines and your premolars have to be directly over the ridge. And that's a fundamental of denture making. And I see so many dentures when they come into me and those teeth are massively buccal to the ridge. And why is that? Because they've tried to turn a class 2 into a class 1.
Well, if you just think about engineering and physics, if they're buccal to the ridge and it's causing like a cantilever, levering sort of effect in that area, it's not going down the force is not it's not going down the correct path.
Well, that's true, but it's more against the balance of muscles, really, because the modiolus muscle will push, or the modiolus insertion will push those
back lingually.
Those teeth, if they're placed buccally, they'll go lingually. So your muscles are not in balance, and it goes back to the analogy with the windowsill I said earlier. That's you pushing on a day that's not very windy.
Well, on that note about ridges, is it true that if you have a flat ridge, your teeth shape should be flatter than if you've got like a pointier, bigger ridge, then you can afford to have deeper fossae on their teeth, like a actual like sharper teeth, if you like? Is that a?
So my question would be, why would you want sharp fossa teeth anyway on a set of dentures? Because ultimately you're not going to help anyone. Your occlusion is going to have to be so nailed on perfect in that case. So really, you need to be flattening cusps anyway on dentures. I'm not saying go back to having flat cusp teeth, but you don't want anything sharp. And again, it's one of the common mistakes people make. So somebody comes in with a 40-year-old set of dentures. There's no cusps on those teeth. And then what we do is we give them a new set of teeth with beautiful cusps. And do you know what? Weirdly, they can't slide the teeth from side to side anymore because they're locked into an occlusion.
So laboratories, when they actually take the stock teeth, do they have like a stock teeth which are pre-flattened or worn, like age-appropriate molars, or do they?
You can. Certain companies do have those. Yeah. So
it just makes sense, doesn't it? Really,
it makes total sense. Yeah. I'm in my 50s now. I've got wear facets on my teeth. We mentioned it earlier. You wear things down, you get used to things. And all of a sudden, if somebody can't make those free excursions when they get their new dentures, they're going to get, the lower denture is going to move because there's nothing to stop it. If their teeth are together, they're trying to slide, the denture is going to move. They're going to get more pain. They're going to get TMJ pain. They're going to get muscle pain. They're going to get all sorts of pain.
Fine. So in the interest of time, I've got one last question before you can give any final closing comments. And that question is regarding probably the stage of complete denture sort of appointments, which is, I found the trickiest, and probably still one of the most important ones, and the trickiest ones I find is the wax jaw registration stage. I remember as a student on the PlayStation playing FIFA with my friend, with my flatmate Harmy, and at 2:00 I've got a patient, I've got to do a wax jaw reg. Can we just quickly revise what the 5 things we have to record are? And I actually remember a lot of times I sort of tap back to that conversation. I remember what the 5 things to record were. So can you give us, the listeners, your main things to record and top tips for the wax jaw registration stage? Okay,
so if you want those, the best way of doing it is there's some Facebook groups around. So I'm trying to do a post a month at the moment to help people with the dentures. I think it was a March post on the for dentists by dentists, I think. And also on there's one called Food. It used to be called Foundation Dentist, but now it's called Food.
I like Food.
And I did You like food, what, generally, or just the website?
Both the group and generally.
The group. Okay. And I did a whole thing about it. And the big tip for me is, if you know that your lower teeth have to go somewhere in relation to that ridge, and it's non-negotiable, okay? Why do we need such big wax blocks? We don't need wax blocks. So I use something called a 3-pillar technique, where I have a small anterior pillar and a small pillar in both molar regions. And by doing that, you're taking a lot of error out of it, because all you've got to do is make sure 3 things gently touch at the same time, rather than a 7-to-7 wax block. So I think the best way of answering that is go onto the website, go onto those Facebook groups.
I'll put those links on. I'll put those posts on so that they can access those group and also
they can go directly to them. Because
So I'll
really. Did you see it, Jazz, when I did it last
night?
Yeah,
I did. I saw it. Yeah, it's very nice.
So I think that will help people because it's very visual.
So everyone, I'll add that on so you can read more about those tips about the wax jaw restoration. So Mark, any closing comments that you want to pass on to listeners about how to improve their complete dentures? I think we covered quite a few things about anatomy, patient expectations, psychology, problem solving. Actually, problem solving we need to actually just cover a little bit about in terms of the patient that comes in for review appointments and they're having pain and problems. You taught me so much. I mean, I still, the only reason I have DICAL in the practice is because of you for complete dentures. And the nurses always give me a funny look every time I ask for a DICAL for dentures. But that's what you taught me.
Do you want to know a funny story about CQC and DICAL, Jazz? So I still use that technique where I use the white from the DICAL just to dry this sore ulcerated tender area, dab it on the mucosa, put the denture in, it picks up on the denture, you adjust the denture. It was one thing that we got a slightly negative mark on because the DICAL was out of date. But I wasn't using it for putting it on. So apparently a little tip for people, if you are going to use things that are out of date, make sure you put it in a box saying out of date materials and you're fine.
Okay, that's a good idea, actually. And same goes with composites, actually, if you're using composites out of date for like shade checking or mock-ups.
Yeah.
That's a good tip.
So put everything in a box saying now not to be used for the purpose they were intended, and you can save these out-of-date materials for that.
You have saved a lot of people in front of the CQC there. So, Mark, any closing comments?
Closing comments is take longer for your dental checkup on denture patients. Take a very, very good history. If you think the dentures are very, very good, and you're not sure you can work out what's wrong with them, don't start making a new set of dentures. If you can't diagnose what's wrong with the old dentures, you've pretty much no chance of making an improvement. So that would be my finishing thing. And be prepared to say to patients, I'm sorry, I think you need a more experienced prosthodontist for this.
Thank you very much. And all those gems were amazing. And I'll put all the other sort of links to your posts on as well. And one thing that we talked about on Facebook, and I can mention it now, is just touching on what you just said, is the importance of the diagnosis. Now, a lot of times for dentists, the diagnosis is going to be edentulous ridges and the treatment plan will be complete dentures.
Right. Shall I put you, I'll put your treatment. Please. Give me a minute. Right. Okay. So here it is. I put this up because I thought we might discuss it. So
you just reminded me now.
It's an example of a treatment plan. So here we go. I've got my book from my course. Course, if anyone's interested, www.thedentureguy.uk.
I'll put a website link on as well.
Cheers, Jazz. So treatment plan. So this is just an example of somebody that I've seen. So I recommend that the patient sees a GDP for alternative medication. So the reason I've done that is the patient's on lots of xerostomach medications, and no matter what I do, if they're on a load of things that make their mouth dry, they're going to get more ulcers. Okay. So next thing, recommend biotin for dry mouth. So this is just a treatment plan for this patient. Make new dentures at an increased OVD. To increase the OVD by 4 to 5 millimeters. So before I start, I already know what I want to do. Ensure that we pick slightly lighter teeth and a similar mold, and send an impression of the old denture to the lab with a photo. Okay. Extend the lowers onto a retromolar pad and increase the retention and stability. Add an upper labial flange, because this was somebody who came in who'd got no flange at the front, but they now can have one, and correct the centre line. So that's one of my treatment plans. Not make full dentures.
Yeah, exactly, which is just funny when you think about it. So very, very thorough, very, it's like almost like creates a little tick box for you as a guide for you to actually what you're delivering.
I have to have tick boxes, Jazz. I'm quite a simple guy.
I love it.
So,
well, Mark, thank you so much.
One very quick thing before we go, Jazz, letter writing as well. I write a letter to everybody I ever make a set of dentures for. I write what I've said I'm going to do for them, why I'm going to do it. And if you get a template letter, it's dead easy to do. It takes 15 minutes to adjust a template letter. And if that saves you having to remake a set of dentures at the end, it's time well spent.
That's a very good idea. And just it's a part of your consent process as well. So that's
absolutely
fantastic. Mark, thank you so much for sharing all your pearls and wisdoms. And it's always lovely to speak to you again. It reminds me of being a dent student again back all those years ago. And it's been a great pleasure. Thank you.
And Jazz, one thing, keep up the good work. It's lovely to see somebody who is an ethical guy who wants to do dentistry nicely, giving these podcasts to people, giving people a little bit of hope that it can be done. So just keep on doing it.
Really appreciate that. Thank you. I'm enjoying it very much. And the plan so far is to keep doing them because it's great. I'm learning. I mean, I learned a few gems from you there, and just with every guest I have on, it's just lots of fun. Thank you so much for watching and listening all the way to the end. I hope you enjoyed that. Anything that I promised in terms of the Facebook group that Mark mentioned and the Atwood classification, I'll put that on in the Protrusive Dental Community Facebook group. Otherwise, I'll catch you in the next episode. Please, if you enjoyed this content, share it with your friends, share it with your prosthodontic colleagues, share it with your dental students if you know any. And also, if you can leave me a review on your podcast platform, I'd really appreciate that. Thank you, everyone. Goodbye.